1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, start of
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
So imagine a patient comes into your clinic.
Okay.
Their heart is racing, their immune system is just crashing, they're losing weight rapidly, and they haven't slept more than like 2 hours a night for a week.
Right. Classic red flags.
Yeah. So you run every lab test available, the blood work is clean, the scans are entirely clear. And as a medical professional, you might think, you know, you're missing a rare virus or some obscure endocrine disorder. But what if the pathogen isn't physical at all?
Yeah.
What if you are looking at the severe physiological shock of a broken heart? Welcome to this clinical deep dive. Today, we are giving you a psychiatric nursing masterclass.
Exactly. And we're focusing on the highest yield clinical reality.
Right. The stuff that actually matters for your exams and your patients, the 20% of clinical knowledge that dictates safe patient care, critical nursing judgments, and, you know, positive outcomes when dealing with the really murky waters of grief and loss.
Because it completely upends our standard medical model. We are so conditioned to look for a localized injury, like a broken bone or a bacterial infection, that we often just fail to recognize when a patient's entire system is buckling under the weight of psychological trauma.
Which is huge.
It is. And as an educator, I see students miss this constantly. You know, for NCLEX-style questions and safe practice, you have to realize loss takes a million forms. It's not just dealing with death.
Right. So let's cut straight to the core problem. Because if we are going to treat grief, or even begin to intervene therapeutically, we have to accurately diagnose what the patient has actually lost.
Which is rarely just a physical person.
Exactly. And when I was reviewing the clinical frameworks for this deep dive, the application of Maslow's hierarchy of needs completely shifted my perspective.
Oh, it's a game changer.
It really is.
No.
Because we usually think of Maslow as like a developmental model, but applying it to loss reveals something so much more profound.
Yeah, because if a patient loses a job, they aren't just sad about a paycheck.
Right. Their brain registers a fundamental threat to their survival and self-esteem. It triggers the exact same neurological alarm bells as a physical attack.
And that neurological mechanism is the crucial starting point for any nursing assessment.
Okay, let's unpack this.
Well, loss is inherently tied to unmet human needs, right? And the brain does not neatly separate a physical loss from a psychological one.
I mean, obviously an amputation or a mastectomy is a profound physiological loss.
Sure, but consider the loss of safety in survivors of domestic violence or, you know, school shootings.
Oh, wow. Yeah.
A school or a home is supposed to be a secure environment. When violence shatters that trust, the patient isn't just traumatized by the event. They are grieving the fundamental loss of safety.
Which is a huge psychological burden.
It's massive. The same goes for the loss of security in a divorce or the loss of self-actualization when a crisis blocks a lifelong dream. The cognitive load on the brain as it tries to map a new reality where that foundational need is just gone is staggering.
Which means our clinical terminology matters tremendously here.
Oh, absolutely.
Because if a nurse mislabels normal mourning as, like, clinical depression, it completely alters the treatment plan. You might be introducing unnecessary medications.
Right, which becomes a patient safety issue. So we need to delineate this for exam logic.
Let's do it.
We have grief, which is the internal, subjective emotion. Then we have grieving, or bereavement, which is the active, exhausting process over time.
Yeah.
And then we have mourning, which is the outward expression.
So mourning is like the cultural container for grief.
Exactly. It's the ritual. When you look at things like sitting Shiva or arranging a funeral, these aren't just polite traditions.
Right.
They are psychologically necessary frameworks that help the human brain process the finality of a loss.
The source material brought up the Oklahoma City bombing memorial, which is just such a visceral example of this.
Yeah, the 168 empty chairs.
One for each person who died.
Uh-huh.
Or, you know, the AIDS quilt. These aren't just monuments. They're physical manifestations of mourning that give the internal chaos of grief a place to live outside the body.
That's a great way to phrase it.
But I want to push back on the physical aspect you mentioned earlier.
Yeah.
We know grief impacts multiple dimensions: emotional, cognitive, behavioral, spiritual.
Right, the holistic nursing model.
Yeah. But are you saying that when a patient comes in complaining of severe indigestion or palpitations or a weakened immune system, that those bizarre physiological symptoms are literally just unexpressed grief?
I am saying they are the direct pathophysiological result of grief.
Wow, really?
Yes. The physical toll of grieving is extensively documented but criminally misdiagnosed in the clinical setting. Grieving isn't just crying, it is an extreme biological event.
So what's happening in the body?
The hypothalamic pituitary adrenal axis just goes into overdrive. You see massive spikes in cortisol and adrenaline.
That constant fight or flight state.
Exactly. And over time, that causes demonstrable changes in the immune and endocrine systems. Sleep disturbances are among the most persistent expected findings because the nervous system literally refuses to power down.
Okay, so if you're assessing a patient with bizarre physiological symptoms, they have a clean toxicology screen and a recent major life change.
You have to consider that their physical distress is the physiological dimension of a shattered reality.
It is so important for clinical judgment. So if grief is this full system physiological and psychological shock, how do we actually measure a patient's healing?
Well, that leads us to the classic frameworks.
Right, the ones we all learn, like Elizabeth Kübler-Ross's 5 stages or Bowlby's attachment theory. But honestly, they feel so rigid.
They do.
We don't need to recite the stages of denial, anger, bargaining, depression, and acceptance.
Yeah.
Anyone in healthcare knows them.
Sure.
But using them as a linear checklist feels outdated, maybe even dangerous, if it sets up false expectations for the patient's recovery.
It is incredibly dangerous to use them as a linear checklist, and exam questions will try to trick you on this.
Oh, good to know.
Yeah, the unifying theme across the modern frameworks like Worden's tasks or Rando's 6Rs is the concept of grief work.
Meaning it's an active process.
Yeah, highly active. Your brain is literally burning massive amounts of glucose trying to rewire its neural pathways to function in a world where that lost person or object no longer exists.
That makes a lot of sense.
It requires tremendous physical and emotional energy. It is not something that just happens to you passively while you tick off stages on a clipboard.
So let me pose a clinical scenario.
Okay, go for it.
You have a patient who seems entirely fine. They have moved through the initial shock. They are back at work. They appear to be in the working through phase.
Right.
And then suddenly, 6 months later, they completely collapse in tears in the middle of a grocery store. How does a nurse evaluate that?
Well,
Is that a failure of grief work? On paper, that looks like a massive regression.
what's fascinating here is that it looks like a regression, but the mechanism behind it tells a completely different story.
How so?
The brain relies heavily on environmental cues. In that grocery store, the patient might have smelled a specific brand of coffee or seen a certain type of cereal their deceased spouse loved.
Oh, I see.
And that sensory input bypasses the logical frontal lobe entirely and strikes the amygdala directly.
Wow.
The emotional intrusion is immediate and intense. So if a patient jumps from bargaining back to anger or experiences that sudden collapse months later, those are completely normal expected findings.
They aren't failing at grief.
Not at all. They're bouncing between stages because the brain is still encountering unexpected data points that contradict its new reality.
Okay, so erratic is normal, bouncing around is healthy.
Yes.
But that leaves me wondering, where is the edge of the cliff? How does a nurse actually spot a patient who is genuinely spiraling?
That's the vital question.
If messy grief is standard, what differentiates an expected response from a high-risk psychiatric emergency?
That requires looking at the social environment surrounding the loss. And this leads us to the concept of disenfranchised grief.
Which is a huge danger zone.
It's a hidden danger zone. It occurs when a loss cannot be acknowledged openly, mourned publicly, or supported socially.
So the grief is essentially rendered invisible by society.
Exactly.
The examples of this in the literature are just profound because they remove all the safety nets we just talked about.
Right. Give me an example you saw.
Well, we're talking about the death of a secret lover in an extramarital affair, or a patient who has an abortion or relinquishes a child for adoption.
Yes.
Even the death of an executed criminal or the loss of a beloved pet. In these situations, the patient experiences intense attachment, but society essentially says, your pain is invalid. You do not get to mourn this.
And because society invalidates the loss, that cultural container of mourning is stripped away. The casseroles don't arrive.
Right.
The employer doesn't offer bereavement leave. The public sympathy is completely absent. So the griever is left in total unsupported isolation.
And that cognitive load we discussed earlier is now compounded by shame and secrecy.
Which absolutely skyrockets the risk of the grief metastasizing into a major depressive episode or, a substance use disorder.
It seems like healthcare workers themselves would be at massive risk for this.
Oh, unequivocally.
Like when you think about ICU nurses, transplant teams, or oncology providers, they form incredibly intense daily bonds with patients.
They do.
And when those patients die, the nurse is just expected to bag the body, wash their hands, and walk into the next room with a smile. There is no socially ordained space for a professional to mourn a patient.
If we connect this to the bigger picture, that is the exact mechanism of professional burnout. Healthcare workers accumulate layers of unacknowledged grief.
Because it wasn't their family member.
Right. The professional boundary dictates that the grief is disenfranchised. This is exactly why we are seeing a rise in interventions like death cafes among medical staff.
I found the concept of death cafes fascinating.
Aren't they?
Yeah. They are these informal, unstructured gatherings where healthcare workers can literally sit down, have a cup of coffee, and just talk openly about death and the visceral grief of their jobs.
It strips away that clinical detachment.
Right, and allows them to process the trauma collectively. It highlights just how desperate the human need for expression is.
Absolutely.
But beyond the hidden nature of disenfranchised grief, we also have to evaluate the clinical red flags of complicated or prolonged grieving.
Yes. Complicated grieving is a severe maladaptive response. It is characterized by intense, persistent grief that actively paralyzes a person's ability to perform their activities of daily living.
So they might stop eating, stop showering.
Exactly. They might become obsessively, delusionally preoccupied with the deceased, or conversely, they might suppress all emotion entirely, presenting with total affective blunting.
It seems like vulnerability here wouldn't just be about the death itself, but like the nature of the relationship.
Oh, 100%.
If a patient's entire identity and self-worth were wrapped up in caring for a sick spouse, losing that spouse isn't just the loss of a person, it is a total loss of purpose that has to exponentially increase the risk.
You hit the nail on the head. Ambivalent, dependent, or insecure attachments are massive risk factors. If they cannot envision survival without the other person, the brain simply refuses to process the loss.
And trauma plays a huge role too, right?
Yes. Sudden, violent deaths, homicides, or suicides shatter the brain's baseline assumption of safety, making normal grief work almost impossible.
And there's a very modern systemic risk factor that we cannot ignore here: visitation restrictions.
Oh, the pandemic. Yes.
The COVID-19 pandemic caused a catastrophic spike in prolonged grief. People were dying in ICUs behind glass. Families couldn't hold their loved ones' hands. Funerals were reduced to video calls.
We stripped away the physical rituals of mourning.
Right, and by doing so, we broke the mechanism that allows the brain to process finality.
Because without the tactile and visual confirmation of death, without the ritual, the cognitive dimension of grief gets stuck in a loop of denial and intrusion.
Which is terrifying.
It is. Which brings us to the most critical part of our clinical mission today: identifying the safety red flags. As a healthcare provider, what are the specific findings that demand immediate, non-negotiable intervention?
I would assume anything that threatens immediate physical safety. Suicidal ideation, obviously.
Yes, but it requires specific assessment. Suicidal ideation with a formulated plan and the means to carry it out is a psychiatric emergency.
Always.
But you also must monitor for homicidal gestures, especially if the loss was due to violence or negligence.
That makes sense.
We are looking for severe depression coupled with absolute hopelessness, when the patient believes the pain is permanent. And we must watch for sudden maladaptive coping mechanisms like a new onset substance or alcohol misuse disorder.
Because if the emotional despair is so deep that they can't move through the grief work.
Right. Suicide or accidental overdoses become very real, immediate threats.
So if we spot those red flags, if we recognize that a patient's grief has crossed the line into a high-risk safety issue, what is our priority when we walk into that room?
Well,
How do we navigate the therapeutic communication without causing more harm?
the nursing process in these moments rests on 3 foundational pillars of assessment. You must evaluate the patient's perception of the loss, the adequacy of their support system, and their current coping behaviors.
Perception, support, coping.
Got it. But above all else, safety is the first priority. You must directly assess for suicide risk in any patient facing a major life loss. You cannot skirt around the issue. You have to ask the direct question.
Let's ground this in a clinical vignette.
Perfect.
Imagine you have a patient whose oncologist just informed them they have an aggressive breast cancer and require a bilateral mastectomy in 2 days.
Okay.
The nurse walks into the room an hour later, and the patient is calmly flipping through a magazine. The nurse asks how they're feeling about the surgical plan, and the patient looks up and says, "Oh, I'm fine. The doctor's overreacting. I don't need surgery."
Wow. That is a textbook presentation of denial.
Yeah.
But clinical judgment requires us to view that not as a failure of understanding, but as a vital cognitive cushion.
A cushion.
Yes. The brain is flooded with terror, and denial acts as a circuit breaker to prevent a total psychological collapse.
Oh, that's a great way to think about it.
The priority here is not to force the patient to face the brutal truth all at once. The goal is to facilitate what we call adaptive denial.
Here's where it gets really interesting. I look at adaptive denial like staring at the sun.
Exactly.
You cannot look directly at a solar eclipse all at once, or it will literally blind you. It is too much energy, too much trauma. You have to peek through your fingers, letting your eyes adjust to small slivers of light at a time.
That's a brilliant analogy.
Adaptive denial is the patient's brain adjusting to a devastating reality in small, manageable increments. But let me stop you there, because how does a nurse balance allowing that adaptive denial with the hard reality of medical noncompliance?
It's tough.
The patient needs life-saving surgery in 48 hours. You can't just let them pretend it isn't happening.
It is a delicate balance, and it relies entirely on the precise execution of therapeutic communication. There are very strict do's and don'ts.
Okay, let's hear the do's first.
The most powerful tool you have is attentive presence.
What does that actually look like?
That means open body language, sitting down at eye level, maintaining appropriate eye contact, and frequently just existing in the room in total silence.
Silence.
Yes. Silence is not an absence of communication. It is a profound, active intervention that gives the patient's brain the space it needs to process the trauma without having to formulate a social response.
It feels counterintuitive because as professionals, we are trained to fix things. We want to fill the quiet with solutions.
Exactly. But filling the air with words usually centers the nurse's anxiety, not the patient's needs.
Oh, that's powerful.
When you do speak, you use simple, matter-of-fact terms. You share observations rather than judgments.
Let's go back to our vignette.
Right. So if, later in the shift, the nurse sees that same breast cancer patient crying quietly, staring at an untouched food tray, the nurse does not say, "You need to eat to keep your strength up for surgery."
Because that's authoritative and dismissive.
Exactly. Instead, the nurse shares an observation. "I notice you aren't eating. I wonder if your loss of appetite might be related to what you are feeling right now."
I love that.
You gently, persistently help them connect their physical symptoms to their emotional reality. You guide them toward the truth. You don't drag them.
That makes perfect sense. It invites them to peek through their fingers at the sun on their own terms. So what are the absolute don'ts? What will instantly alienate a patient?
Do not give specific advice on how they should grieve. Never offer false reassurance.
Like saying everything happens for a reason.
Yes. Or time heals all wounds. Or they are in a better place now. Those phrases are incredibly toxic in an acute crisis. They invalidate the immense pain the patient is feeling in that exact moment.
Wow, yeah. I can see how that shuts down trust immediately.
And crucially, do not judge or try to pacify their anger. If a patient is furious at God, if they are cursing the doctors, or if they are violently angry at their deceased spouse for leaving them,
You just let them be angry.
you must accept those feelings without trying to dissuade or calm them. Your job is to provide a psychologically safe environment for the ugliest, most intimate parts of human suffering.
Okay, so synthesizing everything we have unpacked today, let's look at the 20% that matters most.
The core takeaways for safe, effective practice.
First and foremost, assess for safety and suicide risk immediately. Any major loss is a psychiatric crisis until proven otherwise.
Absolutely.
Second, look past the obvious. Recognize that severe, bizarre physiological symptoms might actually be the body's response to unexpressed grief.
That fight or flight overdrive.
Third,
Oh.
actively scan for disenfranchised grief. The secret relationships, the lost pregnancies, the marginalized individuals, they require a heightened assessment because society has abandoned them.
Spot on.
And finally, prioritize attentive presence over verbal solutions. You cannot fix their pain, but you can share an observation, sit in the silence, and allow their brain the time it needs for adaptive denial.
That is the foundation of exceptional psychiatric nursing.
It really is.
But before we conclude, there is one final lingering variable in this entire equation that we must address, and it is the most important one. You.
The healthcare provider.
Yes. As a medical professional, you are the instrument of healing. You are the one facilitating this incredibly delicate, volatile process for your patients.
Which is a heavy burden.
It is. And this raises a profound ethical and clinical question. If you are carrying your own layers of unacknowledged, disenfranchised grief, the patients you lost but couldn't mourn, the chronic stress of your unit, the slow creep of professional burnout.
How is that impacting your clinical judgment?
Exactly.
Because if your own cup is full of unprocessed trauma, you have no capacity to absorb the shock of the patient sitting in front of you.
Precisely. Are you offering false reassurance because it genuinely helps the patient, or are you doing it because you personally cannot handle sitting in the silence of their despair?
Wow.
Are you making assumptions about their grieving process based on your own unhealed wounds?
It's an uncomfortable question, but an absolutely essential one. Because when you step into that murky, unpredictable landscape of human trauma, there is no blood test, no X-ray machine, and no simple algorithm to tell you where the break is.
No, there isn't.
You are the diagnostic instrument. Your self-awareness, your silent presence, and your clinical judgment are the only tools that can truly locate the fracture, hold the space, and help the healing begin.